My name is Mamas Mamas. I'm Professor of Cardiology based at Keele University, and I'd like to thank the organisers for inviting me to contribute to this important meeting. The remit over the next 10 minutes will be to focus around whether one should use intravascular imaging in every case of PCI. So PCI is like driving a fast race car. This is the Forza 8 hydrogen electric racing car that does 0 to 60 in 3 seconds and has a top speed of over 300 kilometers an hour. Like PCI, it's complex. It has a team working to optimize outcomes. But you would never dream to drive this state-of-the-art machine with a blindfold on. And similarly, I would argue that you shouldn't do PCI with a blindfold on, i.e. without imaging. And it doesn't really matter whether the road is long, such as Highway 10 in Saudi Arabia, which is the world's longest road at 256 kilometers, or complex and tortuous, like Monaco. Because often, the most dangerous obstacles on the road are not the ones that are really obvious, like a big boulder in the middle of the road, but rather the smaller rocks in the road that you cannot see. And similarly, in PCI, the most dangerous anatomy, or the anatomy that prevents you getting optimal results, is not the really obvious things that you can see on the angiogram, but the less obvious things that you can't. There are several randomized controlled trials, over 10 in fact, showing intravascular imaging compared to angiography-guided PCI. And looking at the totality of evidence, intravascular imaging is associated with a 37% reduction in cardiovascular death, a 29% reduction in myocardial infarction, a 20% reduction in target lesion revascularization, and over a 40% reduction in stent thrombosis. There is a lot of data for intravascular imaging. The EAPCI recently released a consensus statement focused around the types of cases that should get intravascular imaging. And their view was that patients with CTO, long lesions, left mains, and complex lesions such as those that are calcified or have bifurcations should receive imaging. They also felt that patients with stent failure, such as stent thrombosis, or restenosis, or those at high risk of contrast-induced nephropathy should all get intravascular imaging during PCI. And this is the consensus take-home messages, that really their view was that imaging is important both from a diagnostic perspective, so assessment of left main, unambiguous findings such as dissection, thrombus, calcified nodules, complex bifurcation lesions, in terms of guiding and optimizing lesions, but also things like ACS, left main, bifurcation with 2 stents. And the EAPCI in their document said that there is less benefit in simple lesions or those with stable clinical presentations. I don't agree with this, and I hope to show you data that would argue against such an approach. So this is the ultimate trial. This was a randomized controlled trial of close to 1,500 patients, randomized to IVUS versus angiographic guidance. And the criteria that were used for optimal stent deployment included MLA of greater than 5 millimeters squared, or stent expansion greater than 90%, plaque burden less than 50%, and no edge dissection. And PCI was judged optimal if all 3 criteria were present. And the primary endpoint was target vessel failure at 12 months, defined as cardiac death, target vessel MI, or clinically driven target vessel revascularization. And this is the main result. This is the primary endpoint, target vessel failure. And you can see that routine intravascular imaging at 1 year was associated with a 50% reduction in target vessel failure. You can also see a similar magnitude of reduction, but not significant because of small numbers, of around 50% in cardiac death, target vessel MI, and clinically driven target vessel revascularization. Again, these latter 2 endpoints show a benefit, but not significant because of the small sample size and event rates. When they stratified the lesions into simple lesions, the A1B1 lesions and more complex lesions, you can see that the benefit of intravascular imaging was no different. So there is much of a benefit in simple lesions as there is in complex lesions. And this is going out to 3 years. This was presented at last year's TCT. And you can see that at 3 years, target vessel failure was significantly reduced. Stent thrombosis was reduced by 90%, and clinically driven target vessel revascularization was reduced by 40%. Again, suggesting that imaging is important. But it's not just about doing imaging. You've got to use imaging to optimize your results. And this is one of the really important parts of this study. What they did was divide patients in the imaging arm into those that had an optimal PCI, defined as an MLA of greater than 5 millimeters squared or greater than 90% stent expansion, plaque burden less than 50% at the stent edge, and no edge dissections. If you had all 3 of those criteria, it was an optimal PCI. And what they showed was that the event rates with an optimal PCI were very low, 1.6% at 1 year. In the imaging arm, where there was suboptimal PCI, the rates were 4.4%, which was similar to the angio group. So it's not just by sticking down an imaging probe that improves your outcomes, it's by acting on it, making sure that your PCI results are optimal. And this is a really important point. The last couple of minutes, I'm going to show you cases where I think imaging is also useful, where not to deploy a stent. And again, you know, it's really important to be using imaging as part of your diagnostic practice. So this is a primary PCI, inferior STEMI, the sorts that we see in the cath lab day after day. I did thrombectomy because it looked like quite a thrombotic lesion, lots of thrombus. And this is what we have. So you would think, well, this is straightforward, just stent it. Well, I did an IVUS, and you can see that the diameter was 9.2 millimeters. And even at the level of the lesion, the diameter was 8 millimeters. So clearly you cannot stent this. If you try to put a stent in this, the stent will not oppose. So I treated with a NOAC and antiplatelet therapy. And the patient remains well at follow-up. So stenting would not have been a good choice in that patient. Here's another case, a lady that had a fine needle biopsy for a mass on her chest, was admitted the following day with chest pain and this ECG. Nothing much in the LAD, just some plaque disease, but a tight lesion in the right coronary artery. So you may think, well, why don't we stent that? Well, I did an OCT beforehand, and you could see that the OCT shows a narrowing, but no thrombus, no evidence of ruptured plaque. And it later transpired that this lady had a Takotsubo, a stress reaction from the fine needle aspirate of her chest mass. Had I stented this lesion, that may have complicated her lung resection surgery that happened a week or 2 later. And this is a final case. This is a great video of a hepatitis B young male presenting with anterior ST changes, troponin elevated, the sort of thing that we see all the time. And you can see a tight lesion in the proximal LAD. So you may ask yourself, well, why is he showing us this case? I mean, this is a really obvious case, a Hep B positive male, tight lesion, let's fix it, let's stent it. Well, here are the OCT images. This is the image in proximal to the vessel. You can see it's an absolutely normal vessel. So immediately that makes you think, is this really a type 1 MI? Is this really a plaque rupture event? This is at the level of the lesion. And you can see immediately that this is not a plaque rupture. This is SCAD. You can see in the false lumen here, intramural hematoma. And you can see inside the vessel here. And again, you can see this is classical of SCAD, intramural hematoma, and spontaneous coronary dissection, and the true lumen here, the false lumen here. And going back to the normal vessel with proper hematoma behind here. So clearly, in this case, stenting would not have been a good idea because all you would have done would have been to toothpaste the hematoma further down the vessel. So in conclusion, in my view, and I think the randomized controlled trial evidence suggests that intracoronary imaging should be used in every case of PCI. Randomized controlled trials showed no difference in the benefit of imaging for simple versus complex lesions. The benefit of imaging is derived from actioning the information and optimizing your PCI outcomes. Imaging is useful. It can help you decide whether to stent or not. And you shouldn't drive with a blindfold, and therefore you shouldn't do PCI without imaging. Thank you.